Hello, I'm Bill Richheimer. I founded the Mile High Eye Institute over 10 years ago. On behalf of myself and the outstanding team here, I'd like to welcome you. My goal is not only to provide world-class treatment, but to make sure you're educated and empowered throughout the process. In this way, it's my hope that you can be an active participant in your care. You may be here because you were diagnosed with keratoconus or told that your exam was suspicious for the condition. If you don't have a firm diagnosis, this video should give you a better understanding of the condition we're evaluating for. If you do have known keratoconus, even if it's been a known condition for some time, I'd still like you to hear the information I'm about to present. I call it Keratoconus 101. Perhaps it'll give you some insights into this important and potentially controllable condition. Now, to kick things off, I'm going to start with some information you almost certainly know. Keratoconus involves the cornea, and the cornea is a clear, transparent part of the eye. If you see my brown eyes in this video, you're looking through the cornea. It's almost like looking at glass on a fish tank. You see what's inside the fish tank, whether it's purple coral or yellow fish, and similarly, you see the brown part of my eye that's actually inside the eye. As you probably also know, a healthy cornea has a dome shape to it. Now, there's some variations on that. I'm just going to use this stack of papers as a prop. But generally, a cornea should be rounded like that. And sometimes it can be a little steeper, a little flatter, but there are limits to that. Now, as the name implies, keratoconus is when the shape of the cornea is off. And the Latin prefix kerato means cornea, and conus simply means cone. So the implication there is that keratoconus means having a cornea that's too steep or cone-shaped. And while that's very much true in most cases, that oversimplifies the condition. In fact, almost paradoxically, a cornea can be too steep and too flat at the same time. So you may think of a cone shape as being something that's too steep, kind of like that. But in keratoconus, what we call the apex of the cornea, the steepest part, can sometimes decenter. And in often cases, it decenters towards the bottom of the cornea. And where my left-hand fingers are, sometimes it actually sags in a way where it becomes flatter than it should be. Now, of course, the pupil is in the middle of the cornea, and that is the part through which we see. And so for many individuals with keratoconus, we're not just seeing through a cornea that's too steep. In many cases, we're seeing through an inflection point between too flat and too steep. Or sometimes you're seeing through a part that's steep, but transitioning to very steep, essentially a distortion in the cornea. And as a result of that, the vision can become distorted in a way that glasses have a hard time compensating for. Now, you've probably heard the term astigmatism before. Astigmatism essentially means the extent to which the eye is not round. And you may have heard that individuals with keratoconus have a lot of astigmatism. And again, that's often true, but oversimplifies the reality. And so we're going to dive in a little bit. There are two types of astigmatism, regular and irregular astigmatism. And I'll start with regular astigmatism. Regular astigmatism is essentially the extent to which the cornea is shaped like a grape. And so a grape, of course, is a non-round object, but one that has good symmetry to it. You could cut a grape in half the long way or the short way, and it's essentially the same object on both sides. Now, this is an example of a corneal topography here. Many hikers in Colorado have seen corneal topographies. Often people hiking a 14er will look at a topo map of the mountains, which indicates the curvature or grade of the mountain. And similarly, a topo map indicates the curvature of a cornea in much the same way. And what we're looking at here in this picture on your right is an example of regular astigmatism. This is a cornea of somebody who has a lot of astigmatism but does not have keratoconus. And essentially, much like a grape, you can envision a grape going in this direction, sort of laying at a little bit of an angle. It would be steeper in one direction and still curved, but not quite as steep in the other direction. It has very good symmetry, as the map shows very good symmetry. Similar to where I mentioned earlier, you could cut the grape in half and it's the same thing on both sides. The importance here is this kind of astigmatism can certainly cause blur in vision, but is often very much correctable through glasses. Whereas irregular astigmatism, by distinction, is really not correctable through glasses. Now, what is irregular astigmatism? Imagine you take a grape and gently depress it with your thumb on one side. Essentially, what you'd be doing is creating a focal depression within that grape, and that is the essence of irregular astigmatism. So if we had to analyze that grape, if you could take away your finger but the depression remained, you would say there was a component of irregular astigmatism, that depression we created, and a component of regular astigmatism, the extent to which it still looks like a grape. And corneas can very much have both. And in typical keratoconus, corneas often have components of regular and irregular astigmatism. And here's an example of an individual's topography of their right eye, and this individual is very typical keratoconus. Now, as we zoom in here, the topographies actually look very similar. This is the component of regular astigmatism. And this cornea, this individual may attain much better vision through glasses. But as we zoom out, you can see the astigmatism becomes very much irregular. There's a flatter spot that's marked off by the purple and a very steep spot, in fact, steep on the top and the bottom. So there's a lot of complexity to it. But the bottom line here is that there are distortions in the cornea that are not correctable by the broad swath of correction through glasses in their entirety. Now, many individuals with keratoconus will have good vision using glasses during the daytime. And that's because the part through which we see is the pupil, and in the daytime, oftentimes our pupil is smaller, so the regular astigmatism will predominate. But some individuals will have trouble driving at night, and that's because the pupil expands at night. So imagine you're in the cabin of your car driving at night, your pupil will get bigger because of the dark conditions, and then all of a sudden these corrections come into the optical fray, and that means that the glasses really can't correct for it as well. And so the irregular astigmatism starts to become more relevant. Now I'm going to show you a different picture that may give you a different perspective on keratoconus altogether. And at first blush, this may seem like it's really out of left field or out of Italy. This is, of course, the Leaning Tower of Pisa. And many people recognize this from pictures on the internet. Some people have been there. I've never been to Pisa myself. But most of us recognize it. And even if you don't recognize it, there's certain things about this building that you can really just guess at, that you can infer. For example, it's pretty clearly ancient Roman architecture. We know that it's in Italy. And it's pretty clear that it was built a long time ago. And you could just guess, well, it probably wasn't built this way. It probably became this way slowly over time. But the real reason I show it to you is you could just guess that the soil upon which it was built is maybe not in the best way for a building like this, or maybe its foundation is not deep enough. But as a more general principle, there's something structurally wrong with this building. You don't have to be an engineer to make that inference. And when you think about it, we're just making that guess from a snapshot of this building, and for some individuals, seeing it for the first time. Well, when we look at keratoconus, and again, here is an individual's eye, their topography, really what we're seeing is the image of something that is, in essence, tilted or misshapen. But what it really means to have keratoconus at a more underlying level is that the structural integrity of the cornea is weaker than it should be. And it's a reasonable inference purely based on the shape of the cornea. Now, as an anecdote about the Leaning Tower of Pisa, they used to let tourists on it. They could go up and down the inner stairwell, and there are certainly photos of people taking their own photographs on top, and they no longer let people do that. In fact, intuitively, to me at least, that was always sort of a dumb idea, because the footsteps of people going up and down this building didn't cause the problem in the first place, but they can propagate it. And similarly, as a structural condition, any external forces, and especially eye rubbing, may not have caused the condition in the first place, but can certainly propagate it, can certainly make it worse. Now, when you think about the treatment of keratoconus, It's really important, in my opinion, to separate that treatment into two categories. One category of treatment is to get better vision. And that's pretty obvious. You're listening to a video from an eye doctor. Of course, you want to have your vision improved as much as possible. But the other category of treatment that's equally important is to attain better stability, as the condition can sometimes be progressive. And I like my patients to think about these two endpoints, stability and better vision, very much separately because the treatments for them are separate. In other words, some treatments that help stability don't necessarily give you better vision, and similarly, treatments that give you better vision don't necessarily make the condition more stable. Now, from the standpoint of vision, many times we want to use a contact lens in keratoconus. As I mentioned earlier, glasses can correct some astigmatism, including the regular components of astigmatism, but can't optically correct for the distortions within the cornea. And some people have more of that than others. If for you as an individual glasses do a good job, that's okay. You can certainly stick with that modality. But for individuals with severe keratoconus, often glasses just don't work to really correct the sight. Now, there are multiple types of contact lenses, but for most individuals with keratoconus, I recommend a scleral contact lens. Now, for perspective, a soft contact lens can sometimes help, but a soft contact lens, as the name implies, is sort of like tablecloth. It mimics the shape of the structure underneath it, and as such, it can reproduce the distortions of the shape underneath it. In other words, if your cornea is too distorted, a soft contact lens just can't correct everything it needs to. And so for many individuals with keratoconus, the optics of a hard contact lens are going to be superior. Now, there are multiple kinds of hard contact lenses, and generally, we recommend scleral contact lenses. A scleral contact lens is one that, when it's properly fit, vaults over the entirety of the cornea. Now, a number of individuals have been fit in the past with RGP contacts, and if they're working well, I don't necessarily recommend that you change it. But for perspective, an RGP, or rigid gas permeable contact lens, can get many individuals to 20/20, whereas if they haven't had that possibility before, and it can really be amazing in that regard. But an RGP rests on the cornea, and as it lives on the cornea, it can sometimes chafe and essentially rub on the cornea. And just like we don't want footsteps on the Leaning Tower of Pisa or external forces on our cornea if we have keratoconus, you don't necessarily want the contact lens itself pushing on the cornea. And that's why, in my opinion, a scleral contact lens is really the ideal solution if it works for you. A scleral contact lens has all the optical advantages of an RGP. It bends light essentially on its own will, creating a new ocular surface through which light bends. But in not touching the cornea, it only touches the sclera, which is not involved in this condition. So all the structural forces are deflected from the cornea. And in theory, it shouldn't propagate the condition the way an RGP may, because it's not putting pressure on the cornea itself. So for many individuals, a scleral contact lens is really the ideal optical solution. It can provide much better vision while not essentially pushing or smushing on the cornea itself. Now, with respect to stability, the other endpoint that we really look for in keratoconus, there are really two main interventions that I recommend for my patients. One is not to rub the eye, and I mentioned that earlier in the context of the Leaning Tower. There's some evidence, albeit circumstantial, that for people who used to rub their eyes and then stop, that intervention, that cessation of eye rubbing, may yield stability. And that, of course, is free, is 100% safe. Now, no longer rubbing the eye, if you had done it habitually in the past, can be difficult to do because habits are tough to break. But it's really important, if not critical, to have that conscious overdrive, to just be extra careful not to rub your eye. You can push on the bones around the eye, push on your forehead, but you really don't want to push towards the soft tissue, and definitely not on the eyeball itself. Now, if you had allergies in the past or have ongoing allergies, those can be addressed. There's certainly anti-itching, antihistamine eye drops that we can recommend. But as much as anything, sometimes it's the force of habit that makes us want to rub our eyes, and really consciously breaking that habit is critical. Now, the other thing I often recommend to my patients who have some instability in their keratoconus or are at high risk for future instability is corneal crosslinking. Corneal crosslinking is a procedure that was approved by the FDA in April of 2016. Personally, I was involved in FDA trials for it, so I've been doing it for quite a bit longer than that. Now, crosslinking is a procedure where we can get the collagen of the cornea, that is essentially the fiber that runs within the cornea, to link to itself in a more tight fashion. That's why it's called collagen crosslinking, such that it's more resistant to change over time. And in doing so, you're less likely to have progression. And that's really the main goal. So in essence, we want the vision improved through a scleral contact lens or whatever means necessary, but often a scleral, and better stability through cessation of eye rubbing and corneal crosslinking. Now I'd like to talk to you a little bit more about the procedure of corneal crosslinking itself. Generally speaking, the procedure itself is quite mellow. It takes just over an hour, and the lion's share of the procedure is really divided into two parts. One, we are giving you eye drops that are made of vitamin B2 or riboflavin. And the goal is to saturate or soak the cornea in these riboflavin eye drops with the idea that they will capture the light done in the next stage. In the next stage of corneal crosslinking, which generally takes 30 minutes, we shine a low-intensity ultraviolet light at 365 nanometers onto the cornea. And the riboflavin essentially captures that light, which initiates the crosslinking procedure. Most people really do very well with the procedure itself, and many people consider it quite mellow. We can have conversations during the procedure. During that time, we'll give you more education about do's and don'ts, as well as recovery and keratoconus more generally. After the procedure is the toughest part. Often that night there's quite a bit of soreness. Some of my patients describe it like having a sunburn on the eye, which is to say that's really not a fun part of the procedure. Most people have quite a bit of soreness for the first 24 hours or so. But usually the next day it feels quite a bit better. There's often ongoing irritation for 2 or 3 days thereafter, but at a lower level. Most of my patients will wear something we call a bandage contact lens, which is a soft contact that has no optical power. It really reduces the severity of any soreness and just aids in the healing more generally. Most people take about 4 days off of work after corneal crosslinking, and then we watch you in the post-operative period as well. Now, throughout the process, we'll give you individualized guidance, and of course, I or one of my team members can answer any of your individualized concerns and questions as we go throughout the process. But I hope this video has been a good primer on what it means to have more keratoconus more generally, some of the treatment options, as well as corneal crosslinking as a possibility. Please ask us any questions as we continue this process, but thank you for your attention today.